breast cancer is a very scary thing. Knowledge is power, and the first thing that we talk about when I sit down with the patient is what it means and what the treatment options are and how to go about through this in a stepwise fashion.
Do you remember high school science class when we were mixing colored chemicals and writing the results on that really tiny graph paper? Well, for most of us, our research careers pretty much ended there. But for those who made it a career path, the success isn't truly found in the lab. It's where those findings make their way into the real world, to doctors' offices, to patients, when the real impact starts to happen. I'm Suzanne Stone, and this is the More Than Pink podcast. Once an idea or a drug is ready to move out of the lab, the next step is clinical trials. The future of the treatment hinges on physicians in the field and their patients. Dr. Vineet Choudhry has been a practicing general surgeon since 2008, but he's really interested in minimally invasive surgery and is now part of a cutting-edge trial targeted toward breast health and breast cancer. So, Dr. Choudhry, you're a general surgeon. How do you get interested in something like research?
Well, research is something that people in the medical field, and especially medical students, are introduced to and involved with from the very beginning. We get exposed to research starting in medical school and then all the way through residency, and research is usually part of almost all residency programs, some degree of research. And there's different kinds of research. There's basic science research, which is more lab work and bench work kind of research. And then there's clinical research, which is research in medicine that's involved more with patient care and direct patient contact. And so you can kind of go either route when you're considering research. But again, all of us are exposed to it during our training, and we can choose to kind of remain involved with it or not once we get out.
So as you have progressed through your practice and seeing patients, obviously continuing to pursue that research in a clinical way has been interesting to you. Absolutely.
And part of for me in my practice is I've always wanted to continue to remain up to date on the newest technologies and techniques, and kind of remain on the head of at the edge of the curve of advancing medicine. And so part of that being new technologies, new devices, but also new research and new trials out there as well too, to the degree that I can be.
So you're involved in a clinical trial that I think would interest a lot of breast cancer patients and just the breast health community in general. Can you tell us a little bit about how you got involved in it and what you're doing?
So I got involved with it. I was exposed to the technology, the cryoablation technology, several years ago, and essentially had someone come and expose me and market it to me, and explain to me what this is all about. And that's kind of what was my first exposure to what cryoablation was. And at that time, and even to date, the cryoablation is FDA approved for treatment of benign breast tumors, and specifically fibroadenomas, for treatment of that as an office-based technique. And so this was already being done, and at the same time that I initially got exposed to the technology, I was also informed about this trial that was ongoing. And as part of my practice the whole time, I've always been treating women with breast cancer. And so when I heard about this new trial that's out there, it really intrigued me as far as a different kind of treatment option for women with breast cancer. And again, I personally like to expose my patients to all different options and every option that's out there. And it was exciting to me to be able to expose them to an additional option that this was. This trial is called the FROST trial, and it stands for freezing instead of resection of small breast tumors. So most trials have acronyms that they try to bring along with it. And what this trial is essentially doing is studying the use of cryoablation for early stage breast cancer, for treatment of early stage breast cancer instead of the standard treatment, which would be surgery.
So no surgery and you get rid of breast cancer. That seems like a pretty big deal.
It is, and if this bores out to be a viable treatment option, then this will drastically, potentially change the way that we treat breast cancer. Because as of now, really surgery is the only option for treatment of even early stage breast cancer.
So how does this differ from surgery? So most of us, we're going to come to you and say, okay, I've got breast cancer. We've got to get rid of it, or cut it out of me. So can you kind of walk us through what is this freezing thing? How does it work, and why is it so much? Why could it be potentially so much better than the surgery option?
So yes, so again, standard treatment currently would be that you come to me and you have a breast lump, and that's been proven to be cancer, and we would take you to surgery and do either a lumpectomy or even a mastectomy on you, along with sampling of the lymph nodes within the axilla or armpit region. And again, that's kind of the standard care in addition to additional post-operative treatments such as radiation or chemotherapy. So how cryoablation differs is that instead of removing the tumor surgically, we insert a large bore needle into the tumor and infuse liquid nitrogen into it, which essentially freezes the cells and kills them. And the great thing about this is that this is an office-based procedure, and it's very similar to the needle biopsy that most women will get to get the diagnosis of cancer to begin with. So we do it in the office under ultrasound guidance, and it's done under local anesthetic, so there's no general anesthesia involved, no trip to the operating room, no trip to the hospital. The entire procedure usually takes about 30 to 45 minutes. We make a small nick on the skin and again insert the needle, and under ultrasound guidance infuse the liquid nitrogen into it. There's very minimal discomfort or pain associated with it, and people can essentially go back to their normal lifestyle right away afterwards. And so there's no recovery or downtime. Family members can be present with them during the procedure. So there's logistically a lot of nice benefits associated with doing cryoablation versus surgery. And again, it eliminates all the recovery that goes along with it afterwards. And what we're trialing and what the trial is looking at is to see if this is an equivalent treatment option to surgery for that.
So this sounds like some sort of miracle. I'm sure we're going to have listeners out there right now who are saying, wait a minute, what? I could do this without anesthesia, no operating room. Sounds kind of almost like a cure that's so much simpler. Does the trial talk to us about what happens after? Is there still the chemotherapy or still that radiation treatment that happens after that?
Right. So right now the trial is looking at a very limited subset of women. So it's not necessarily open to any woman with breast cancer. Right now there's two different main arms or stratums of the trial. And one stratum is considered the lowest risk stratum, and that's for women ages 70 or older that have a small breast tumor less than 2 centimeters in size, no evidence of any disease in the axilla or armpit region, and then favorable hormonal factors within the tumor that's determined on the biopsy. And so if women fit within that category, then they'll be a candidate for this trial. And for that stratum, the treatment within the trial is to get the cryoablation, and then and no surgery, no sampling of the lymph nodes, no radiation afterwards, no chemotherapy afterwards, and then they are recommended to have a 5-year course of hormonal therapy, which is basically taking a pill every day. So that's the lowest risk group within this trial. And then there's a second arm or stratum, which is a little bit of a higher risk group, which is women ages 50 to 69. And mostly the same factors are being looked for: small breast tumors, favorable hormonal factors, no evidence of spread or disease within the axilla. And in this group, they will get cryoablation, but in addition, they will be recommended to follow up with radiation therapy to the breast and the hormonal therapy, but no surgery and no chemotherapy.
This certainly would represent a significant change from standard procedure that most women are presented with today.
Correct. Yes, this is quite a shift in the standard of care currently.
So essentially what's happening is the tumor, you're freezing the tumor. Where does it go? I mean, doesn't it stay in the body? And should we be concerned about that tissue still sitting there?
Actually, it doesn't. The body will reabsorb the tissue. So the cryoablation procedure, again, destroys and kills the cells, and at that point it becomes essentially a foreign body within our body. And as a part of the natural immune response of an individual will be to send factors and send cells to reabsorb and destroy that tissue and remove it from that area of the body. And this is another part of the treatment that's being studied as well, which is this immune response that occurs after the cryoablation, which is part of how the tumor is dissolved away. And that immunity that's being used to dissolve the tumor is being studied as potentially a additional treatment factor within it, meaning that this immune response that you develop and the immunity that you develop to these cancer cells can then potentially act as almost like a chemotherapy and be able to fight cancer cells of the same type in different parts of the body. So again, it would potentially be a type of chemotherapy, but a immune therapy that is a natural response of the body to additional cancer cells.
So it's really a 1-2 punch. First, you're able to eliminate the cancer tumor itself, and then second, your body is going to reabsorb that and then make sure, hopefully, that if those cancer cells try to develop again, the body is now able to respond and get rid of those cells before cancer progresses.
That's correct.
Okay, sign us all up. So when you're presented with a patient who fits this, or let's say somebody's listening to the program today and says, "Hey, ooh me," raising their hand, how do they go about being part of that trial, or how do they start a conversation with their physician if they're not in Austin, which is where you're located? How do they start having a conversation with their physician about getting something like this?
Well, the best way to do that is, so first of all, if you fit within those categories and within those age groups, then you're, again, a potential candidate for this. And most women are not going to know offhand the exact tumor biology of what they have. But again, if the biggest, broadest strokes of the trial itself is the age group. So if you fit within those age groups and you have a small breast tumor, then you may be a candidate. And the first thing to do then is to have that conversation with your primary physician and ask about whether you could be a candidate for this trial. And then your physician can then either reach out to the study designers or study facilities, including myself, and then ask if their patient would be a candidate for it. Alternatively, the patients themselves can reach out directly to the facilities who are involved with this trial, and so a potential patient can simply reach directly out to me or any of the other study facilities and ask for a consultation and ask for a visit. And the best way to know if you're a candidate or not is to come in for a visit, and we can look over everything and see if you would qualify or not.
How long have you been a part of this clinical trial, and what are would you be willing to kind of share, what are those early findings, whether they're scientific or anecdotal? How are your patients responding?
Right. So I've actually been part of the study since 2013, so for the last 4 years now. And so far, it's the initial first couple of years of the trial was actually even more limited and was restricted only to women ages 70 or older who had this same kind of tumor. So it was that kind of lowest risk stratum 1 that I spoke about earlier. Those were the only women initially being enrolled in the trial. So the criteria recently got expanded to include a younger age group, but initially there wasn't many candidates that were candidates for the trial, and so far to date there have been 2 women that I've treated for breast cancer with this. Both of them were actually off protocol, though, because neither of them actually fit within the protocol study design. So they weren't officially enrolled in the trial itself, but wanted to have it done nonetheless. And so we followed essentially the same protocol with them, but again didn't enroll them in the actual trial. And both of them have actually done very well so far. One of them had a complete. This was early on also, and when I was doing this, had a complete response with no residual findings on imaging or on exam, and again that was one of the early cases, which was now 4 years ago, and has had no recurrence so far. The other individual was kind of lost to follow-up to me, so I'm not sure how she's doing now, but as long as I was following her, she had no evidence of recurrence of the cancer. So far the anecdotal evidence is good. However, again, the study itself, and I do want to emphasize that this is still an ongoing study, and so we don't know the final results of it yet and what it will show and bore out eventually, and whether it will be proven definitively to be equivalent to surgery or not. But it's certainly what we're trying to investigate and prove.
So there is a anecdotal but small correlation, and it seems to me that maybe one of the barriers for you as a physician and for every physician who's out there now that, or even the guys in the lab, so they create this, they do all the research, they do the study in the lab, come to you to initiate those clinical trials, and it's hard to find people.
Yeah, that's probably the hardest part is to find the correct, the right candidates. And all of these trials are set up and designed in a very controlled and very deliberate stepwise fashion to make sure that we're doing it in the safest way possible for people. Because the last thing we want to do is to do something that may harm somebody or have a negative impact on patient care. And so the trials are done, again, very deliberately to ensure first that the treatment itself is safe to do, that the cryoablation or whatever technique is safe to begin with, and then that each step that's added, we want to make sure that we're not going to ultimately, again, do harm to patients as we're trying to test a new treatment or technique. So that's why a lot of times these trials are very limited initially. They're slow to build up, and again, trying to find enough people that would fit within certain categories can be challenging at times, and that's why trying to get the word out about these things is really key and crucial for trials like this to help enroll folks that are the right candidates for it, who again are going to be safe enough to go through this kind of treatment right now.
So, what kind of an impact can you see something like this having on your patient population?
I think that to be able to offer multiple treatment options to patients, including standard surgical techniques as well as newer techniques like cryoablation, will really enhance both my patient population, but also treatment options, across Austin and the surrounding areas in general. Breast cancer is a very scary thing, and the first thing that we talk about when I sit down with the patient is what it means and what the treatment options are and how to go about through this in a stepwise fashion. And knowledge is power, and when women are able to understand what is going on with them and understand all the different treatment options, it really allows patients and women and their families to be able to feel comfortable with what's going on and be able to get through it.
What a powerful option to have if this works the way everybody's hoping it does.
Absolutely.
Anything that you would share with a patient, any guidance you could give them when it comes to clinical trials? I know a lot of people or patients are hesitant to enroll thinking they're going to get a placebo, or they're not going to get the best treatment that's possible today. Is there any guidance you can give them?
Yeah, specifically to this trial, this is a single-arm trial, so this is not the type of trial that has a placebo in it, first of all. So there's not even that option. There is only the only arm in this trial is patients getting the actual cryoablation. And what we're doing is we're comparing that to historical results of surgery, which we know about already. And so every woman who's enrolled in this trial will get the actual treatment. And again, the study and the trial was designed in a way to try to make sure that it's done in the safest way possible. So there is careful and extensive monitoring of the tumor and of the disease after the cryoablation to ensure that it is treated completely. One of those parts being that it is rebiopsied 6 months down the line to ensure that it's still treated and gone and there are no residual cancer cells. And it continues to be monitored carefully after that for a 5-year period going out. And so if there's any evidence of recurrence, the minute if there is any recurrence of the disease, then you're shifted to a standard treatment option of surgery and beyond. So the trial again is designed to try to be the safest way possible. So you get the significant potential benefits of being able to do the cryoablation and avoid surgery and the other standard options. But if there's any failure of it or if it doesn't work, then we quickly can shift you to the standard treatment options and get it treated appropriately.
Is there a timeline for when all of these physicians who are around the country who are participating in this trial, is there a timeline for when it ends? When do we know if it works? Right.
So there's not a chronographic timeline. There's a kind of a more of a number limit. So we're trying to enroll a total of 200 patients into this trial, which is a pretty decent number. And when we hit that number, that's when the trial will end. And right now there's a total of 9 patients that have been enrolled. So it's early on in the process, and so we do still have a ways to go, and there's a lot more room for enrollment. But as soon as we do hit that 200 number, whenever that is, then the trial enrollment will end. And then the follow-up will still, and the data collection will still continue. And again, the follow-up is going to be a period of 5 years to make sure that there's no recurrence or to see what the results are in that time period. So for this particular trial, there'll still be a few years out before we have the final results of it and know, what the results are.
Well, I think I will speak for a number of women out there to say our collective fingers are crossed.
I agree.
We like options. The option of having an in-office procedure to get rid of your early-stage breast cancer tumor, as opposed to surgery in the operating room, would be amazing. Dr. Choudhry and so many physicians and researchers like him are working to give us more options, less invasive options, life-changing and life-saving options. Clinical trials and participation in them are the key to the progress. A big thank you today to iHeartMedia for making each and every single podcast happen. Thanks, Mike, for putting all the pieces together. Thanks to the entire Komen Austin team for all their research, their graphic design, and just making sure I get to the studio on time. Susan G. Komen Austin is an affiliate of Susan G. Komen Breast Cancer Foundation, and if you need resources, information, or have a comment about this or any of our episodes, reach out. You can find us at podcast@KomenAustin.org and visit us at KomenAustin.org. I'm Suzanne Stone. Until next time, be more than pink.